Hello, and thank you for joining us for another episode of Matters of the Heart, a program brought to you by Haverhill Community Television and Pentucket Medical Cardiology. My name is Dr. Srivastava. I'm here today with one of my colleagues, Dr. Seth Bilazarian, and we're going to talk about something that I think we've touched on before in the past, but a lot has changed in the field, and the bigger picture, we're talking about atrial fibrillation, an irregular heartbeat condition that's pretty common, but the treatment for atrial fibrillation, it's really evolving and changing. We have new medications at our disposal, and so Dr. Bilazarian thought this would be a good time to review these new medications and compare them, and some of it we don't know the answers quite yet, but it'll be a good discussion to have, and maybe with that I can turn it over to him to start talking about these new drugs that are, I think, going to really change the way we treat atrial fibrillation. So I'll hand this over to Dr. B.
Sure. So let me give you some just general information just to review for our audience. I think we have, as you said, talked about it. But you mentioned this problem called atrial fibrillation or AFib or AF. It's an irregular heart rhythm in which the upper chamber just wiggles instead of pumping. Because it does that, blood can stagnate in there, and when it stagnates, it can clot. If it clots, our biggest fear is it will go to the brain and cause a stroke. So that's the short story about the AFib. And what do we do about it? Well, we know if we thin the blood, it dramatically lowers the risk of a stroke. So if you thin the blood, and before 2 years ago, our only option was thinning the blood was this medicine called Coumadin or warfarin. It's the only thing that we had, but we know you lower the risk of stroke by about 80%. Really dramatic benefit. If you don't use it, you have risk is much, much higher, 5 times higher than if you take Coumadin. But we had no other option.
Well, what's the downside? Why? So what's the problem?
Well, Coumadin is a medicine that's been around since the 1950s. It has some issues. It doesn't play nice with other drugs. So if you take other drugs or if you drink alcohol, you take an antibiotic because you have an infection, the Coumadin gets all messed up. If the Coumadin gets messed up, it can get too high in your blood, and your blood can get too thin. You can have a risk of bleeding. It can go too low, and then you're not protected from the blood thinning effects. So those are the main things. And even if it's all going well, you have to have your blood level checked every single month. So those are the things about Coumadin briefly. So we have always wanted to have options. So 2 years ago, we got a drug came on the market called Pradaxa. It was the first of these new drugs. Doctors refer to these drugs as NOACs, N-O-A-C, new or novel oral anticoagulants. So NOAC, NOACs. So we now have 3. And the reason why I want to do our program is right here at the beginning of 2013, we have the 3rd NOAC. So I mentioned 2 years ago we had Pradaxa. Then about 1 year ago, we had a drug called, generically called rivaroxaban, but its brand name is tough. It's Xarelto, but it's spelled with an X like xylophone, X-A-R-E-L-T-O. Xarelto was the second one. And the third one has just been approved by the FDA. It's called Eliquis, E-L-I-Q-U-I-S. So we now have warfarin and 3 new drugs. So I want to have a fun talk with you about it because neither one of us have had any experience with it except you and I participated in a study of it before it was approved. So we participated in it coming to the market, but we haven't used it because it hasn't been available yet. So I'm excited to talk with you about how you think you might use it in your practice just to get some fun dialogue with you. Sure. But I'd like to just say generally, my thinking about this, and I want you to tell me if you think differently about it, is I think we have Coumadin and then the 3 new drugs. There are some differences in the drugs, but they're sort of similar enough to say it's sort of old or new. But some people don't agree with that. If you agree with that, that's fine. Some people say we have to think about it as 4 separate different drugs. So it's different how you might think about it. So that's the first question. But let me just say what's common about these new drugs, or the NOACs as we refer to them. So Pradaxa, Xarelto, and Eliquis. They're all short-acting. You take them and they go out of your blood in a couple days. By 3 days, they're almost all gone, and by 5 days, they're definitely all gone. So they're sort of short-acting. They can only be used in people who have normal kidney function. They don't have to be tested, so you don't have to have your blood level checked all the time like Coumadin or warfarin.
That's, I think, the big win.
I agree. Yeah. And they're new, so they're not generic, so they're expensive. So patients will pay more. Even if they have insurance, they'll pay more because their co-pays will be higher. And we have some pretty good data on them, and we'll talk about the data. But all 3 of them are at least as good as Coumadin. Some of them are better than Coumadin in protecting from stroke. And they're all about as good with regard to bleeding. Some may be a little bit better than Coumadin in bleeding. But that's, I think, a good summary of the 3 novel or new or anticoagulants. But the biggest thing is no nuisance issues. And the second issue is they are expensive. So if you don't have insurance, they probably can't even be afforded. They cost over $300 a month if you don't have insurance. If you do have insurance, you might pay $25 or $50 for a copay per month for the new drugs. Any thoughts about, before we go into the newest of the new, any thoughts
No,
about your experience with the new drugs?
I've had good experience with them. There's a learning curve with a lot of them and things, and I was going to first say that I agree. I sort of view it when I'm talking to a patient about it, just like you broke it up, that there's the old way of doing it with Coumadin, and there's these new drugs. And I kind of lump them together, understanding that there are some nuances and differences between the two, but for the sake of conversation with somebody, lump them all in together. I think it makes it easy to discuss with somebody. And we've on the show before, we've talked about Pradaxa, we've talked about the clinical trial called the RELY trial that brought that to market. Do you want to review those again, or just jump to the newest one that came out?
Well, I thought what I might do is I might give sort of my thoughts about these drugs and have you weigh in on what your thoughts on. So if I had to give like a couple of words, if we just talk about the new drugs, so we're lumping them together for our purposes, I think you and I think similarly. Just talk about so Pradaxa. What is the sort of deal with Pradaxa? Well, the Pradaxa study said that it was better at preventing strokes than Coumadin. It was about the same in terms of all bleeding, like really serious bleeding was about the same. It had higher rates of stomach bleeding, and it had lower rates of bleeding in your brain. So the bleeding was sort of a wash, some bleeding a little bit higher, some lower, but all bleeding about the same, but it was better at preventing strokes than Coumadin in patients with atrial fibrillation.
And so for me, the one take-home thing I've learned is anybody who's had a prior history of gastrointestinal bleeding, I've shied away from them. I mean, is that sort of what you've been doing as well?
I think so, because one of the things that you're right, it does have a high rate of GI bleeding, but even more importantly is the way they make the drug Pradaxa is it's coated in acid because it helps it absorb it into our bloodstream better. So that acid coating can irritate the stomach. So certainly, as you said, so if someone has a prior sour stomach or peptic ulcer problems or problems like that, the Pradaxa is more of an issue.
Yeah. And I've had people who take it develop more heartburn or GI distress or discomfort here.
And sometimes has to be stopped for that reason.
Or taking it with food seems to help to some extent. But so that's the one lesson I've learned with that drug, and that's the one thing where I think if I'm going to pick one for somebody, I shy away from Pradaxa for that reason.
So the one other thing I guess I would say is that if you talk about the issue about this as a new drug, people have probably seen some advertisements, this 1-800-BAD drug. There's some concerns. But the problem is that new drugs, in my mind, get really excess scrutiny, and the lawyers who sort of go out of their way to sue people and make a living from that have promoted this idea that it's a bad drug. In my mind, the data is pretty compelling that it's as safe on the risk of bleeding side, but it's better in terms of preventing stroke. So that's the data. We can't say it doesn't cause problems, but what's our alternative, I guess?
Yeah, well, to go along these lines, these commercials, because I don't fully understand how one can go on and make these claims without anything to back them up. I mean, is there any pushback to get rid of these commercials that you know of, or is there?
I mean, I don't know of anything. I mean, I think that if people want to, I think in our society, if people want to sue someone, that there are lawyers available for doing that. So I guess that's the message, and I think that obviously some of these lawyers have done a good job in making a living suing. Now, I in no way am suggesting that people don't have some bleeding issues with this drug. Right. The question is, you shouldn't be on the drug if you don't need it. But if you have atrial fibrillation and you're at risk, there's a certain score we use, we haven't talked about, but we discussed previously, called the CHAD score. If you go on and check your CHAD score, you have atrial fibrillation. If you have a high rate risk of having a stroke, doing nothing is bad. So then your options are either the old drug Coumadin with its issues we discussed, or one of these new drugs. Right. The only other thing I'll just finish with the Pradaxa is I will say that it's a twice-a-day drug. So the Coumadin is a once-a-day drug, usually taken at dinner time. The Pradaxa is a twice-a-day drug, but it doesn't have the other issues. It doesn't get out of whack when you take an antibiotic. It doesn't get out of whack when you take alcohol. It doesn't get out of whack with a lot of other drugs. So that's the sort of nutshell of the Pradaxa.
So now maybe we'll just quickly summarize Xarelto before we jump to the newest one.
Okay, Xarelto is a medicine that was studied in another trial, and that trial was called the ROCKET trial. And the ROCKET trial looked at patients who were at much higher risk of a stroke than the other two drugs tested. The other two drugs tested people who were at a low to medium risk of a stroke, but the Xarelto drug studied it in the higher risk patients. And what they showed was that there was no difference compared to Coumadin. It wasn't better and it wasn't worse than Coumadin in preventing strokes, and it wasn't better or worse in terms of bleeding. So we would say it's equivalent in the higher risk patients. And that's one of the challenges that you and I face, because you can't really directly compare, because one drug looked at it in lower risk patients and the other drug looked at it in higher risk patients. The Xarelto, I think, has a couple of issues. Number one, it's a once-a-day drug. It's not an issue, but it's a once-a-day drug, but it can be taken it's recommended to be taken in the evening with your dinner meal. So it's once a day, so you can't take it in the morning like most people take their once-a-day pills in the morning, so it's supposed to be taken at supper time with your dinner. So that's one of the issues with Xarelto. It's I guess, an advantage because it's once a day, but it's a disadvantage because you have to take it at that time. The other issues about Xarelto is it has a couple of these, what doctors call black box warnings. And black box sounds bad, and it is bad because the FDA has said there's a couple things that you have to be cautious about. And one of them is they say you have to be very cautious if you stop the drug because there's a high rate of, because the drug only lasts for a couple days, you can have a stroke after stopping it for a couple days. And the second thing is they have to be very cautious if you take Xarelto and then have surgery and have a spinal anesthesia. So those are the things that are cautious. Now, I don't think that that's different in my mind than the other new drugs, but it was labeled on this drug, so we all have to be cautious about that because it's a specific warning on this drug. So that drug is another good option, but it's another.
And how about the
new agent.
kidney issues in that drug?
Well, again, I think they're all the same in my mind. All three of the new drugs should not be used in patients who have not normal kidney function. And there's a way for us to figure that out, but that's a general thing.
And then now, so that's a great review of the two ones that we already know about and we've talked about before, but now this newer one that just came to the FDA, Eliquis.
Right.
Tell us a little bit about that one.
So Eliquis is the newest drug. It's been approved. It's been developed by two really big drug companies. Pfizer and Bristol Myers are bringing that drug to market. And they studied it in a study that you and I participated in.
Can I just interrupt you?
Sure.
Are these all the same class of drugs? Are they all the same? You know, just like cholesterol medicines, there's multiple types of statins with different brand names. Are these all the same?
It's a great question. No, so the Pradaxa is in a class called direct thrombin inhibitors. And these other two we talked about, Xarelto and the Eliquis, are what's called factor Xa inhibitors. And what that really means is where they block the blood clotting process. The way our body clots is our liver makes different proteins that clot. So if we cut ourselves, the way we stop bleeding is by clotting at the site where we're bleeding. So which protein it targets, which protein it blocks is what's discussed. Warfarin blocks it at two different places. The Pradaxa blocks it at factor 2, and these factor Xa inhibitors block at factor 10. So that's really that's the story. So the Eliquis is the newest drug, as we said. You and I participated in this study that's bringing it to market called the Aristotle study. Now, what's different about Aristotle and the other studies, it was bigger, and it's one of the things that happens in medical statistics. The bigger the study you have, if you have a difference, you can say it's more significant if you have more patients, because we're more confident. So just briefly, if you have a study of 1,000 patients and there's a 1% difference, you may not be able to say that that's significant because you can't be sure based on the mathematics of statistics. But if you have a 10,000 patient study and you have a 1% difference, you may be able to say it's significant. So the folks, to their credit, that developed Eliquis did a much bigger study than the other two trials. And because they did that, they're able to say that they were statistically significant in some really important areas. They can say that they are more beneficial in preventing strokes than warfarin, which is the same as Pradaxa. But they also are able to say that there's less bleeding than warfarin, which the other two drugs can't say. And they also can say that there was actually a benefit on mortality or death, which we really like to see. We love to say we're giving a drug that has a lower rate of death. So of these three drugs, I think they're going to have the greatest ability to market because they can go to doctors and say, look, we are one of the new drugs, we're the newest of the new drugs, but not only are we lower risk of stroke than warfarin, we also have lower bleeding and we actually prevent death compared to warfarin. So I think that's going to be a powerful marketing strategy, and I suspect they're going to go on the TV and we're going to see marketing ads that say, look, this drug does all those things and doctors should use it.
Are there any red flags or warnings or anything?
Well, it does not have any of those black box warnings that I described that the Xarelto has, so it's a little bit easier or less risky for us from a standpoint in that regard. But again, I think there's a lot of similarities, so I don't believe there'll be any difference between this and the other drugs. If you stop it, in 2 or 3 days it'll be out of your bloodstream, you're at risk for a stroke. So even though the FDA made the Xarelto people put a warning in, I think it's the same for the other drugs in my opinion. I would say that one thing that they didn't put in as a warning, but all the drugs have, is that there's no antidote. Right. So God forbid if someone's on one of these drugs and they're taking it appropriately, everything's going well and they should be on it, but if they have a serious accident, they're cutting trees and they cut themselves with a chainsaw, or they're in a fall off a ladder, or they're in a car accident, these patients are at risk, and we don't have an easy way to quickly reverse the blood thinning effects. The good news is that the drugs wash out very quickly, so in a couple days it's gone, but in the short run they are at risk compared to other options, or not taking a drug, or even with warfarin, which we can give patients a kind of blood product to prevent ongoing bleeding. So I think that's the highlights of that I would say. So what I think will happen, if I can predict, is that only about 10% of Americans are currently getting these new drugs as of now, even though we've had the Pradaxa for 2 years and we've had the Xarelto for about 1 year.
10% of atrial fibrillation patients.
Right,
Okay.
exactly. So 90% of patients are still on warfarin. There's a lot of theories around that. People say that it's, a lot of patients are uncomfortable with new drugs, or people don't want to spend the money, or some doctors, particularly primary care doctors, maybe are hesitant about trying these new drugs. So I'm predicting, in my own view, would be that as we see a third drug come to market with more people promoting it, more TV ads about it, so more patients are asking about it, we're going to see a growth in these drugs. But for the first 6 months, we're here in 2013, the beginning of the year, we won't see a lot of adoption in this part of the world, because in our part of the world, there's a lot of oversight from the HMOs and the insurance companies to not allow the use of new drugs for about 6 months. So by the end of this year, I suspect there'll be a lot of growth in this new drug, but I think all the drugs will see a growth because there'll be a lot of talk and enthusiasm about these NOACs, or novel oral anticoagulants.
And how do you envision or predict, comparing the three, which one might rise to the top or lead the way in sales? Or because it sounds, I mean, if the viewing audience, I think, would jump to the conclusion that Eliquis is going to be the winner.
I think that's the conclusion of most people will say. I think that my view is that the Eliquis and the Pradaxa are really very similar, and it's a function of that statistics that I described that makes Eliquis look better.
So let's review that one more time then. Why? So how many patients were in the Rely trial? 18,000 or so?
Yeah, so the difference is that the way the Pradaxa patients were handled in their study is they had 3 different groups. So one group got just warfarin, one group got low-dose Pradaxa, and one group got high-dose Pradaxa. So they compared ultimately the high dose to the warfarin, so it was a smaller study because that middle group wasn't included.
Right.
So it's a smaller study. So it's really like a 12,000 patient study.
Right, so it's 6,000.
In each arm.
Yeah.
Yes. And then the Eliquis, I don't remember the exact number in the Aristotle trial, but it was much larger. So they had what doctors call power, or statistical power, to say, look, there was clearly a difference that showed a benefit, even though it looks very similar in terms of the amount of difference on the efficacy side. Now, the bleeding side looks very much stronger for Eliquis to give it its due. So I do think that that's going to be a likely benefit for that. So the question is should we? A couple questions come out. Yeah. You already asked the one question. I think by the end of the year, we're going to see a lot more people prescribed and enthusiastic about Eliquis for new patients. My view is if someone's doing well on Pradaxa or Xarelto, it doesn't make any sense to switch to a new drug if they're already doing well on it. Right. But for new patients going in who want a new drug, or the NOAC, probably there'll be a lot of Eliquis use, I'm thinking, in the second half of this year in our part of the world. Now, in other parts of the world, they don't have the oversight we have in New England, but I would say in our part of the world, we're going to see more growth in the second half of the year. But the bigger question is, and I guess I'll ask you, do you agree with my contention that there's going to be more of the newer agents because of this third agent, or will there still be a lot of warfarin use? Is warfarin going to sort of go over the horizon here in the coming years? I thought it would be already at this point, so I would have predicted that.
I just think you alluded to a lot of reasons why, and I would add to a lot of it's more work. This is going to sound bad, but it's work for the physician to stop the status quo. The patient's already on Coumadin, they've been doing it for years, doing fine. There's more work involved in trying to not convince, but educate about the new drug, stop this one, start the new one, and things like that. And maybe there's a component of not wanting to rock the boat or change. People have been doing fine. I mean, I think that'll play a little role. It shouldn't be a large enough role to really thwart the NOAC's success. I don't think it'll ever go away. Obviously, it will never go away because there's people who can't take the new ones.
Right. And
there are other conditions for which these new, and actually I want to be clear about that, these new blood thinners are really just for atrial fibrillation. they're not meant for folks, in certain types of atrial fibrillation, but they're not meant for folks who have mechanical heart valves and things like that.
Well, what you just said is true, but it's not completely true because they have been approved.
Oh, you're right.
The Xarelto has been approved for clots in the legs.
Yeah, you're right. Sorry.
So you're right.
Yeah.
So of course, the manufacturers want to expand the indications because that's their market.
Yeah.
That's how they make more money. It's not a bad thing, but that's what they do. But you're right. The caution you said is very important.
Right.
Warfarin is the only medicine we have. If you have a metal heart valve,
That's what I really wanted to focus on.
warfarin has to be the drug. Some physicians, unfortunately, the reports have been from Canada, have gotten the NOACs and had bad outcomes. They've actually clotted, had serious things happen to them. So we have not done that. We're sticking to the rules, but we're focusing today on atrial fibrillation.
I mean, I've had people ask me, can I go on Pradaxa now, who have a mechanical heart valve? And so I want to always keep raising that point that it is not.
Thank you for
that at all.
emphasizing that.
So to answer your question, I don't think, if Coumadin's here right now and the NOACs are here, I don't know, hopefully.
What timeline was that?
Yeah.
Those hands are moving over. Is that a 1 year or a 3-year timeline?
I think more of a 3-year.
So
I
in
think
3 years, your hands
especially around here, I just find that the newer medications take a long time to, maybe it's the part of it is the oversight, some of it is maybe conservative nature of the physician in this area, don't jump to new things right off the bat and wait a little bit. And maybe same with the patients, they sort of want to cautiously watch and see what's happening. I've had a lot of people who just say to me, it's too new for me, want to wait and see, because it seems like every time I look, the FDA is coming out with a new reason why a new drug is being pulled back or something. And so I think it'll be more than a year, to answer your question.
Okay.
And what you think it's ready to explode?
No, I don't think. I think not 1 year for the reason I described, because we're not even going to be able to get access to it for 6 months because of this cautious approach that the insurance companies take to allowing a new drug. So we're really not even going to get it until the second half of 2013. There is in 2015, a fourth drug, NOAC, will be coming. That will be it. We'll have 4 NOACs. There's nothing else on the horizon. Right. But I think between, in the year 2014, 2015, I really expect it to be about at least 50-50 in the marketplace. One of the things that I think is that we didn't talk about is there is a cost related to Coumadin management. The cost of going to the blood, get the lab test, get the physician to manage the Coumadin. That's not an inconsequential cost. So although the cost of the actual pill is higher for the NOACs, there is a total cost of care that has to be considered for the newer drug.
And when I first started using the first one, Pradaxa, I got the sense that the insurance companies, different departments don't speak to each other.
Right.
They jack up the cost of the drug, but don't realize that the savings is going to be met on another, and they don't
or
do
at
that
least
analysis.
offset, maybe not met, but at least offset.
And they don't do that calculation.
Right. No, it's exactly that case. Just for our audience, and I know you know this, that the way that things work is that the insurance companies contract with something called a pharmacy benefits manager, a PBM, and they give $10 million, some amount of money. So your insurance company, whether you have whether you have a Blue Cross product or Harvard or Tufts, gives $10 million, I'm making up a number, to a pharmacy benefits manager like Express Scripts or Medco or one of these types of companies. And they basically are responsible for it. So they only care about the cost of the drugs. They don't care about the whole cost. Right. So it takes a couple of years for this whole thing to work out as a total cost of care for patients. And the other thing, of course, is what's the cost of care of preventing a stroke? I mean, if we talk about these newer drugs like Pradaxa and Eliquis have both been shown to reduce strokes, of course we want to do it just for the benefit of our patients, but there's a cost of stroke. A cost of stroke is enormous. The cost for rehab and for getting patients speech therapy and swallowing therapy and getting patients a walker, those costs are enormous. So we have to think about the cost of prevention as well in terms of the total cost of care. So that's another piece that actually complicates this matter.
So we have a few minutes left. Maybe let's maybe humor me here. We'll walk through the exercise. Pretend I'm a patient coming in with a new diagnosis of atrial fibrillation.
Okay.
And let's say I'm 70 years old with high blood pressure, diabetes.
Okay, let me do it real quick.
Yeah, so how do we have this conversation in the office?
So you have atrial fibrillation, sir, and you have an irregular heart rhythm, and I tell patients that their upper chamber was wiggling, and you're at risk for a stroke. So we have this 5-point scale that we use called the CHADS score. And the CHADS is CHADS, congestive heart failure, high blood pressure, age over 75, diabetes, or a previous stroke. And you have how many of those, sir?
So I had 3 of those.
You have 3 of those?
Yeah.
So we know that if your risk is if you have 1 or more of those 5 points, you should be on a blood thinner. If you have 2, you definitely should be, but the new rules say if you have 1, you should be on one of these NOACs. So I want to offer you these two options, sir. And one option is this old drug that's been around for 50 years called Coumadin. And if you take the Coumadin, you have to be cautious about what you eat. You can't eat certain foods that contain vitamin K. You can't drink alcohol without severe moderation. And you have to be very careful about other drugs. But that drug's been around for a long time. So if you don't like a new drug, that's your option.
That drug?
That drug, like all of these drugs, has a risk of bleeding because it's thinning your blood. But the biggest concern about it is it can be variable up and down. And we didn't talk about this, but some patients have a genetic problem that makes it very hard to manage Coumadin. About 10% of people have that. So I tell patients that, there's basically a couple things. There's a cost issue because the newer drugs cost a lot more. There's an issue about your kidney function, so I have to make sure your kidney function's okay before I can even offer you one of these new drugs. There's an issue about, are you willing to be an early adopter? Do you have a problem with stomach bleeding? And I would say, do you have good insurance coverage? So those are, I think, the big issues that help us decide whether the new drugs are an option. If you have good kidney function, you have good insurance, you're willing to try a new drug, and you don't have stomach bleeding, then that's an option, and we can talk more about that. That's usually my fast approach.
Great. No, that's great. And a very similar approach. And I think we're starting to run short on time here, certainly, so we'll start wrapping this up. But I think it's an exciting time for, coming into practice. It's neat to see these changes while in practice and revolutionary types of changes. That I think it's really going to change the way we care for atrial fibrillation and the convenience factor for patients and quality for patients, because the Coumadin can really be a nuisance for a lot of people.
Let me just ask briefly, do you offer the NOACs to all your patients? I mean, even offer as like a brief conversation, or do you feel like if someone's doing well on Coumadin, you don't even mention it?
Oh, no, I feel like part of our job is every visit to educate what's new, what's going on, and hear the options and why I think this might be good for you or not good for you.
Sure.
Because there's some people in whom I know it's not going to be a good drug for them. They've had ulcers or they've had kidney failure or something, but I'll still tell them about it
and tell them
why we're not considering it, so they
Right.
don't go home and think, well, why didn't he mention that?
Right.
So,
Great.
so no, it's an exciting time. Very excited about these things. It was a great review of these 3 new drugs and how they fit into our treatment plan for atrial fibrillation, and hopefully we can have another discussion when the 4th one comes out.
Yes, in 2015 we'll schedule it.
We'll be on our, 300th show or something by that point.
That's good.
So with that, we'll close this up and conclude. And so another episode of Matters of the Heart was brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. I was joined by Seth Bilazarian. Thank you for joining us.